is advocacy with the community. I'm just going to tell you a little bit about Mr. Venkat. He was inspired by the teaching of one of India's greatest philosophers, Swami Vivekananda. He became a social worker at the age of 22 with a mission to serve the underprivileged. After joining the Vivekananda Kendra in Kanyakumari, he became a full-time volunteer and was posted in Arunachal Pradesh, which is one of the most remote states in the northeast part of India. He expanded educational activities in these remote areas. He also realized that with education, there was a need to focus on healthcare as well. Post that, in 1998, he joined Karuna Trust. Karuna Trust aims to provide healthcare to a population who has no access to healthcare. He became a trustee of Karuna Trust in the year 2002 and a secretary in the year 2010. Karuna Trust manages 71 government primary health centers under the public-private partnership model. These centers deliver healthcare in communicable, non-communicable, mother and child care, and immunization. It covers a population of close to 1 million people. They follow the comprehensive healthcare services model, which is of prevention, promotive, curative, and rehabilitative services. Currently, he is the Joint Secretary. He's involved in planning and execution of various public health programs and projects at Karuna Trust. He's also started pursuing his Master in Public Health from London School of Hygiene and Tropical Medicine. So thank you. Mr. Venkat, are you there? So welcoming Mr. Venkat. Welcome, sir. Thank you for joining us today. Thank you.
Thank you. Sorry, I'm really sorry. Due to unexpected traffic jam, I got stuck in some places. A lot of construction work is happening in Bangalore city. That's the reason I got stuck. I'm extremely sorry. Shreya, I would like to get the background of the people so that I'll be able to talk to them.
Sure. So we have participants who are healthcare professionals who are also have had experience with palliative care or are caregivers for someone who needed palliative care or have had any sort of lived experience of any illness as well. And basically, the main aim is to provide, they wish to provide palliative care or healthcare services to their communities as well. So they are all well-wishers of palliative care and healthcare in general.
And they are from where?
All over India. All over India, sir.
Okay. Okay.
Yeah.
Okay, good. So as Shreya was explaining about, introducing about Karuna Trust, Karuna Trust believe in comprehensive primary health care. And India has one of the best comprehensive primary healthcare designed well, very well designed, but unfortunately poorly executed. The reason for poorly execution is resource constraint. Unfortunately, India is spending very low finances for the primary health care. We spend only 1.5% of our GDP for the entire healthcare. Not only primary, it is primary, secondary, tertiary. So we spend only 1.5% of the GDP of India. That is the lowest spending anywhere in the world. Asia, in average, Asian countries, average they spend around 5 to 6% of their GDP, and US spend around 16% of the GDP. And we spend around 200 rupees per person per annum for comprehensive primary health care. So that is the lowest spending. But our aim for this 200 rupees is the comprehensive primary health. So that means we are supposed to do mother and child care, communicable diseases, non-communicable diseases, immunization, and other additional services also. And now the preventive, promotive, curative, and rehabilitative services. Initially, rehabilitative services were more towards disabled people or challenged people. Now, one more component is being added is palliative care into the rehabilitative services at the comprehensive primary health care level. So, with the lowest spending and 200 rupees per person per annum, covering around 25,000 population in the rural areas, it comes to around 50 lakhs rupees for the each health center budget. So with this so much of constraint in resources and spread across various services, as mother and child services itself is a huge challenge. We have one of the highest infant mortality, maternal mortality, and anemia. Almost 50% of our pregnant women are anemic, and around 40% of our children are stunted. So these are very, very disturbing indicators. See, not only the present generation health is in bad shape, and even our future generation, above 40% of our children stunted means even our future generations are affected. So with this kind of challenges, even in mother and child care itself, you have a huge challenge. And then we have the communicable diseases. Communicable diseases that tuberculosis, which is the biggest killer. In fact, 50% of the tuberculosis patients in the world are in India. So it's a huge challenge. We have a cure for tuberculosis, but unfortunately, compliance, detection, case findings is the big challenge. Unless we have a very robust system, this is a very challenging disease, not the coronavirus. In fact, unfortunately, the entire focus of communicable diseases has gone to COVID. But this year, that means just a year gone by, we have already 23% less notifications, TB notifications already. That's very, very worrisome, because that means we stopped detecting the new cases or less detections. Already we have a lot of problem in detection. During the last 1 year of pandemic, we have neglected TB, and which is 23% we have notifications are less. So what happens because of that? We are spreading TB very rapidly. Why I'm mentioning this is that unless you have a very robust communicable disease management, we are getting into the problem. Then another important is non-communicable diseases. Non-communicable diseases, we have biggest killers, diabetes, hypertension, cancer, and the other NCDs. And then the NCD screening and identification and the management. And with all this, and then the palliative care and rehabilitative services. So this entire gamut of services, it has to be done with this kind of resources. So that is where actually India is, we are lacking. Unfortunately, the focus is more on secondary and tertiary care services. Of course, the money that what we are spending, even for the secondary and tertiary care, is very less, which is not enough. So, with this kind of low resource allocation for health, we can see the consequences already. Luckily, our frontline of health workers are very strong, especially after NHM, National Health Mission, has come into existence. Our frontline has becoming more robust by, especially after adding ASHA into the communities. Community health workers, basically, they are able to reach out to the last mile. With that, actually, we are able to keep our health system reach out to the last mile. In fact, when we were interacting with global public health experts during this COVID, they were all surprised the way we are able to reach the last mile through ASHA and ANMs. So we have developed a particular structure, but there is a lot of need and efforts in strengthening these structures. But at the same time, you need a lot of money. So that is why we are all people, those who are practicing public health for last 20, 30 years. We tell the government to increase their allocation of funds to at least to 3% of GDP. And in fact, the government of India has promised by 2025, they will increase their allocation to 3%. And everybody was very eagerly waiting this year's budget and thought that there will be substantial increase of allocation for the health budget. And when we look at the figures, we thought actually they have increased it, and in fact almost doubled the budget this year. But when you look at details, what the government did was they have included water and sanitation into the health budget. By adding water and sanitation into the health budget, they added almost 1.2 lakh crores into the health budget. It looked like that they have doubled it, but actually in real terms, actually the budget has come down. I'm talking about union budget. And we are in fact waiting for the state budget to be presented, especially in Karnataka, and we wanted to look at it. Anyway, this is the long story, and in fact, we are struggling for so many years with this kind of low resources. Unless we improve this the allocation at the primary health care, I think we have stretched maximum. I don't think anybody can stretch beyond this. Beyond this, it's going to collapse. The amount of work the auxiliary nurse midwifery people do, it's mind-boggling. And the same thing with ASHAs. ASHAs are supposed to be a part-time health activist, is not even an employee. She is not an employee even. She is just an activist, a community health worker. In fact, we are dumping so much of work on her. It's almost equal to the work of auxiliary A&M work. So, why I want to say this is because it is we are stretching it so much. It's coming to a breaking point, including our clinicians. Our people are managing more than 100 OPD per day, and antenatal checkups, school health screenings, NCD screenings, health and wellness kind of preventive work, immunization, all put together, we have fully stretched. Unless we augment the resources, augment the human resources, and augment the infrastructural resources, including equipment, including telehealth, including networking, communication networks, which you can leverage a lot of services out of this spending. There is so much of promise from the governments that definitely will be increasing it. And it was very unfortunate that Union government has not increased it actually this budget. And everybody has seen the consequences of one pandemic where the whole economy went into recession. And the consequences of that recession in different aspects of life is huge, which actually nobody has even quantified. Nobody has the time and energy to look at the consequences of this recession and this impact of the pandemic. One pandemic, which one communicable disease. So, why I'm insisting and emphasizing all these things is because there is a very urgent need to strengthen the front line, the comprehensive primary health care, and which is highly neglected. And everybody talks about secondary and tertiary care. And another important thing, because you are all practicing professionals, that's the reason I'm bringing it to your notice, that another important thing is we means the government, started buying services from the private sector through different insurance schemes. And either Ayushman Bharat or through state government insurance schemes, the government started buying the secondary and tertiary care services from the private sector. So the huge allocation of money for that is being given, but unfortunately, it is not an additional allocation, but it is an existing allocation. From the 1.5% of the GDP, only we are spending even for the insurance schemes. So because of that, what is happening is existing secondary and tertiary care services of the government are getting weakened and weakened. So at one point, again, that is another worry for us, that it may have a very bad consequences. Anyway, so this is the background. With this background, and I wanted to come on to the what you call the palliative care concept at the community level.
So we're sharing it from our end, the presentation. Yeah.
Yeah, can you go back? This is the first one. go, please go next. One second. And the palliative care is the two things. One is institutional support. Another is community based. Institutional based palliative care has become uh, very complex, and very resource intensive, and a lot of strain um, in all aspects, into the to the institutions and to the families who are under stress. And Karuna Trust found that the rehabilitative services and palliative care should be community based. Uh, Community based services will bring down the lot of stress on so many things, including resources and the entire the management. And also it is more sustainable because of the presence of the community around the family, and family, friends, and the healthcare system in the villages. That's the but thing is, we need to augment towards the needs of the palliative care. That is where the challenge is. Yeah, go next, please. So here the base is very broad here. The broad base of a different aspect of palliative care is at the community level. How do you look at this community level services? It is making the people aware that you can take care of the affected people. I'm actually combining the rehabilitative services and palliative care services both together, because we are looking at very comprehensive. And this one, the different institutions which are available in the villages, like we don't count them proper as institutions. Like we have something called Anganwadis. We have something called self-help groups. We have something called village health and sanitation committees. These are all at the village level. These are actually institutions which are supposed to take care of the health of the people. And apart from the self-help groups are a bunch of women come together and organize it for a certain purpose, like a microfinance purpose, financing purpose, but they all can be used for palliative care purposes. Like, for example, if you look at Gachirauli in Maharashtra, where one of the highest maternal mortality and infant mortality is there, and also it is a extremist area, where a doctor's couple, stayed in the villages and trained class 4 to class 7 women as the community health workers, and could able to reduce the IMR and MMR to the Millennium Development Goals levels. So why I'm mentioning is that if you involve the community and especially self-help groups and train them for the purpose of the rehabilitative and palliative care services, that will be the base that we have available. And then you over and above that base, we have this primary healthcare system, starting from ASHA at the community level. And then next level is sub-health center, that is ANMs. ANMs, we have, the sub-health center, we have two health workers. One is male health workers, another is the female health workers. And then go up to the clinical services like a doctor and a nurse and a pharmacist and a lab technician, lab facility, lab services. And then next level of services is specialist, which is very, very narrow band. So this is how we need to design rehabilitative and palliative care services. Next, Sri. So as I was repeatedly telling you about the how do you develop the base. So in a particular village, we need to have this resource mobilization. We call it as a resource mobilization. We have, as I was mentioning you, Anganwadi workers. Anganwadi teachers are actually, they are very well trained. And we have something called, a teachers community. Teacher community is very well educated and they can be used for certain purposes. And then we have, as I was mentioning about self-help group members. And then the ASHAs we have. ASHA basically is an activist and also they are now getting well trained and by incentivizing their services, actually that is a very good resource available. And then you may be having local institutions at the villages. Now you may be having private hospitals, private nursing homes. And then another very important resource available is RMPs. RMPs, they are not qualified, but they have a certain experience which can be used for this particular work. So a basic need for community-based palliative and rehabilitative services are initially mobilizing these resources, identifying and mobilizing and organizing them, and give them the training. I'm not talking about a very high level training. It is giving them the basic science behind the palliative and rehabilitative services. And then give them that confidence that they can handle it. And one of the biggest hindrance and challenge in this is the fear. The fear that this has to be handled only by experts, by only specialists, that has to be removed. So that can be done only through trainings, and the training gives them the confidence. Once they start handling palliative care services and rehabilitative services, that slowly the confidence will build up. Next. Here, next. So as you know, primary health care, as I was telling you, now we have something called government as introducing 100,000, 1 lakh health and wellness centers. One of the component of health and wellness center is not only the mother and child care services, and you need to take care of the wellness. So under the wellness, government has introduced certain things like, for example, yoga and nutrition and Ayush systems of medicine. And all that can be used for the palliative and rehabilitative services. This is only, we have 600,000, 6 lakhs sub-centers in the country. Out of 6 lakh, they declared 1 lakh centers as health and wellness centers. So slowly that number will increase. So to that extent, our services will improve. And also there is a manpower, additional manpower doctor, maybe an Ayush doctor, maybe a dental doctor, maybe a trained nurse are being posted at the wellness centers. So all this infrastructure, all these resources can be used for the palliative and rehabilitative services. And certain additional equipments are also being provided at the sub-health centers. Then now one more important thing which is going to come up is the network. All most of these health and wellness centers are will be connected through for a telemedicine kind of a purpose, including primary health centers. The primary health centers also will be connected. So with that, what happens is this will become a very a robust front line which can be supported through specialists through technology. Yeah. Next, please. So this is so having all these facilities and the resources at a different scattered kind of a situation. So how do you handle all these things? And most important in this entire thing is the identifying the resources and people's willingness and their commitment and work for take up the challenges in the odd hours. See, one of the big problem in palliative and rehabilitative services, it is actually 24 hours service sometimes. Sometimes you need to attend at the odd hours. So the preparing the people's mindset for the different kinds of services, that is the most important. And then train them, identify them, organize properly, and motivate them for the need for this, and also incentivize. See, voluntarism of pure non-monetary levels, it is not sustainable. It will, as long as you are enthusiastic and you are willing to do, it will be sustainable for to some extent. But we need to incentivize little bit. It's almost like we have to recruit the community volunteers, almost like an ASHA kind of a level. ASHA is not an employee, but ASHA is part of the health system. The same way, the community workers for the palliative and rehabilitative services, we need to recruit in that level, and then we need to train them, and then incentivize. Incentivize is also important. But because of that, it will become an institutional framework, and then it becomes more sustainable and more long term, and it will become a more robust, and also they will get dignity, and they will also get a recognition, and slowly it will become an institution in itself at the village level. This is how we have to be organize and train these people. But another important aspect of motivating and putting this manpower into action is a lot of the negative aspects in the village, which actually, even though you want to work, but you have you will not get that kind of support system. That is due to some kind of a myths and some kind of wrong information, superstitions. All that need to be handled case by case, and it has to be scientifically you need to counter that. Like, for example, I'll tell you, sometimes certain things, it looks like a myth, and it looks like unscientific. But we need to also very carefully understand each myth and each information which is actually working against the community work. For example, I'll tell you in BR Hills, where we have started our work, Soliga tribes is one of the primitive tribes in the southern part of Karnataka. There, the women here, they deliver baby in a squatting position. And the allopathic doctors who conducts, actually we have a hospital in BR Hills. When Dr. Sudarshan, who started this, founded this organization, he wanted the pregnant women to lie on the obstetric table. They refused to lie on the table because they're traditionally they do the delivery of baby through squatting position. So it looks like it is very bad practice, and it is it is not a not scientific. But actually, if you go deep into that practice, actually it is more scientific than keeping pregnant women on the labor table. Actually, it is inconvenience for the people those who are conducting the labor than the pregnant women. So sometimes this myths or the certain practices, it looks like that they are unscientific, and it looks like that it is not in line with our practices. But we need to look at both the angles. So sometimes the health system also have certain practices which are like as I told you. That is actually, if you look at the how do we conduct the labor on the labor table, it is inconvenience for the people those who are conducting the labor, not to the convenience of the pregnant woman. So we have to handle this myths and information about different kinds of palliative care and rehabilitative services. So I don't want to go deep into each myth and all that, but you have to have that backup with you. Then only you will be successful. Otherwise, it will push you back because you will not get the acceptance. Unless we get the acceptance, we will not go further. Whatever the level of intensity of effort that we put, it will not successful. It may take little more time. We need to make the entire community, not entire community, but the most important components of the community, we should get the acceptance. Acceptance of the work is acceptance and involvement and the ownership of this work is very, very important. Otherwise, we will all get tired. You with the commitment and your passion for doing the work, you will be what you call will be doing it, organizing. But it is humongous kind of work. You will not be able to do if you don't get the support from the community. So it is the community acceptance. It is at different stages. We have to go very slowly. Sometimes you will get this acceptance very fast, and sometimes it will take years. Sometimes you will never get it. Sometimes you will never get it. But that is the till you get that acceptance, till you get that involvement, that ownership. Till that time, you are not successful. It is still work in progress. Once you get that acceptance and you get the ownership, community accepted it as their own work, then it is highly sustainable, and it will grow very fast. And we have to put all our energies, all our effort in achieving these goals. So we have to be very systematic in each step, identifying the resources, the training the resources, and the motivating all of them and incentivizing them, and then removing all the negative aspects about the services by dispelling the myths and giving the correct information, especially scientific information behind the services. And biggest acceptance will come after seeing the results. Once people started rehabilitative services, when you see the better performance of the people, those who are receiving the services, better performance in the palliative care, people pain, you have reduced the pain, you have reduced their suffering, and that is these outcomes, that gives the more inclusiveness and more acceptance. You have to get that acceptance. I'll tell you a small story that when small incidents rather, Dr. Sudarshan, when first initially went to BR Hills, that is the Soliga community, deep in forest. Today it is a tiger reserve. When he went there, the tribes used to run away because he used to take his clinical bag, and then he used to go there to the hamlets. They used to run away, and it was a Herculean task for him to actually to even to screen and just wanted to see their health. And he was keep going, and he was trying to get their acceptance. And he had come from Bangalore, studied in Bangalore Medical College, went into such a remote place. People into the Soligas, they except the old and children, everybody used to run into the forest. So one day there was a snake bite, and that the person was actually uh, lying, and Sudarshan came to know about this, and he went there, and he did a small incision and removed all the poisonous blood, and gave antivenom injection that the patient revived. This was the turning point. And the people thought that this man has something. So the acceptance will come once people see the results. And this is how we should, it is a very long drawn process, but we have to be very, very patient. And patience is very, very important in this whole exercise. Then once we get that, it is easy to expand and easy to go into the next level, and people will take it on their own shoulders. That's how you get the ownership. Next, Shriya, anything? Yeah, that's what I was telling about the village level, village institutions. VHNC is very, very important. The body at the village level, village health, sanitation and nutrition committee, sanitation and nutrition. But basically, you should look at the health. So this body actually is a multi-sectoral body. One of the member is Jilla Panchayat, Gram Panchayat member, and one Anganwadi member, and one school teacher, one representative maybe from an NGO, and Asha, sometimes ANM. These are all members. And this VHNC also has certain amount of money, 10,000 rupees they have per annum. And at the urban level, we have MAS, that is Mahila Arogya Samitis. And these are all women-based Samiti committees, and which also have now under NUHM, National Urban Health Mission, they also are being provided with certain small money. That's maybe, I think, 10,000 rupees per annum. So the VHNCs are a very, very important component linking community to the institution. Because this is being official body of the primary health care at the village level. So this is where we can use this. And then another important is schools. I told you, teachers, and educating the children about different palliative care and rehabilitative services, where they can also be partners in the whole exercise. And the local, we call them opinion makers. Opinion makers, they are very, very important. Sometimes opinion makers actually, the most important opinion maker in the village is a teacher. And the village, the temple pandits or pujaris. And then elected representatives. And these are all, and then some of the NGO representatives. These are all opinion leaders. And then anyway, Panchayat is there. Panchayat basically have resources. They can take up certain work, certain the equipments, and certain infrastructure, and all that can be provided by Panchayat. And over and above, you have primary health care to support all that. So ultimately, what we have to do, all these institutions have to be well energized and well acceptance for the entire work that we need to involve them. And then, as I was telling you repeatedly, the participatory approach is very important. And it has to be, we should not go with certain rigid approaches, rigid paths, and we should know the science behind the entire work, and we should be only rigid on the science, not about the processes. Processes can be different, but of course we should never compromise on the science part of it, but we can compromise on the processes. So that is how it becomes more participatory, and we have to be participatory. And use of technology now, beautifully, a lot of startups are coming, and a lot of innovation are happening. Technology is going to be the biggest tool for the community-based services, because you need expert support, and that all can come through technology. Yeah, next please. So yeah, as I was telling you, we can start at one component at one level. Best is to start at the community level and slowly build up the other components. And certain very, very critical support system we have to build initially, and that is the most minimum kind of, especially nursing and some of the equipment, all that should be at our available. Then add on the support system and augment the entire services. That is how we should build up the entire thing and make it very robust and very functional, community-based, community-owned palliative care system. Yeah, next. Here. Yeah. So as some of the models, you are aware that one of the model is Kerala. It basically we need to have this catchment, or because if you spread your the network very wide, then and your net very wide, it like yours you will become very thin in your approach. So we need to have our catchment. What is my catchment? And you should have that should be very clear. This Kerala model, 10,000 patients at any point of time, all the services are free. And also, what is the geographical area that you are going to cover? All that should be very, very demarcated. Yeah, next. These are some of the models you can go through. Yeah, next year, go ahead, go next slide. Yeah. And this is the same thing, just repeat only whatever I was talking. So, in fact, the community-based services should be supported at one level by the palliative institution, which is little higher services. Sometimes you need to have 24 hours care, and there you cannot give at the community level. It has to be institutional. So that institutional mechanism should be available. Then only the community level system will be successful. So we need to, in the beginning itself, we have to identify which is my nodal agency, nodal center, and specialist center. All that, then only the community-based work will be successful. Yeah. Next. So one of the important aspect of this whole work is volunteers. We have to identify, we have to train them, and we have to motivate them. We have to sustain them. That's sustenance also is very, very important. Yeah. Next. So, and the training part, actually, we have to be very, very careful. We have to be have a proper training manuals and proper time schedules, and but at the same time it should be very flexible, and little bit of theory, more of practical hands-on training, and including making certain equipment, certain support systems. All that should be part of the training, and more on hands-on training. That's how we should handle. Next, Sri. So different roles we can assign to volunteers, and you can assign these roles based on their strength, their skills. And initially you have to identify those skills and those their strengths, and then build on that and give them training, and they can be assigned certain jobs, certain particular jobs. Then on the other way, we should be very careful. We should not crisscross. No, today you give one job to one volunteer, and the same volunteer you give another job tomorrow. That actually it won't work. You have to be consistent on giving a particular type of work to volunteer, so that he will be confident and he will be delivering efficiently, and he will become more and more efficient. And he in turn he will be able to train others in the coming days. So we have to be very, very careful. Each person does the different kinds of identifying the person with a particular skill and a particular assigned work. Not so much of multitasking. Of course, we need to do multitasking, but not so much of multitasking. Yeah, next please. So that's what this is. Everybody's business. You have to take care of it. It's very unfortunate condition, and we need to have that empathy, sympathy, and care to take care of the patient, and that is definitely everybody's responsibility. Unfortunately, today it is only the responsibility of the family. It is not the responsibility of the community. Less responsibility to the institutions now, presently. But we have to convert this into more community taking responsible and more institutions giving the support to the community. That's how we should build up and remove or lessen the burden on the family. Today, family is the only unit which is taking this responsibility. Now, we should transfer this burden from family to community to the institutions. That's how we should keep working. Next, please. Next year. Yeah, these are all different models. And there are, you can also charge, and there are business models and all that. Yeah, next, please. So this again, Kerala. So this I am giving you for an examples. Next, please. Yeah, again, see, one of the important thing is here, Kerala state is very advanced in palliative care. And so I think people from all over the country, in fact, you need to look at very carefully, critically, and the learning aspect the Kerala model. In fact, if you look at all over the country, there are two states which are very progressive in healthcare delivery. That is Kerala and Tamil Nadu. And we tell the whole country, you just follow Kerala and Tamil Nadu models, including primary healthcare delivery. And in fact, we will be achieving the Millennium Development Goals within no time. And unfortunately, we don't follow the models which are available. And because if you look at their indicators, health indicators are much above the national averages. And they have already achieved wonderful results. And our job is just pick up those successful models and put that into practice. That's all. We need not have to reinvent the wheel. And that's why I'm just telling there are models, and go deep into it. And you need not have to pick up the entire model as it is. Please take the only successful components which will be applicable in your area, which will work in your area, but which doesn't work, no need to take it up. So which you may have to innovate this whole whatever is not working. That's how we should take up the models, because generally what happens, we take up the model, entire model, and we try to implement in other area. That generally don't work, because a lot of variables, cultural variables, and then educational levels variable. There are so many variables. All that you have to take it into consideration. Next, please. So with this, I think, thank you very much for this opportunity to talk to you. And I wish all of you very success in your endeavors and your efforts in taking the palliative care to the community. And it's a very important work, and highly neglected area. And unless one is committed for this and passionate about this, it will not go to the community. With this, I will close, and I'm happy to take questions. Thank you.
Thank you so much, Mr. Venkat. The floor is open now for questions. We have some questions in the chat box. Samuel, would you like to start with your question?
So you want me to read or?
Yes, please.
Yeah. Now, can I go ahead with the question, sir?
Oh, yes, please, Sam.
Okay.
Yeah.
Okay. So you mentioned about the allocation being 3%, or it should be 3%. But by the year 2025, the government said that they would raise it up. But if that is the case, if that's the snail space at which they're going to keep raising the allocation, by 2025, probably we'll need probably 5% of the GDP to be what should be allocated. So if we are going to depend on the government alone to do that, it's going to be a very long haul and a long wait, and many people won't get the benefit. So I was wondering how a group like ours could be getting involved, and what can we do? One is we try to create awareness about the need, and what else is there that we can do as the general public and people who are aware of the need? How can we help?
No, see, the allocation of funds 1.5 today our allocation is 1.5% of the GDP. In fact, the government says it's 2%, but actually we spend only 1.5% of the GDP. The promise is that by 2025, gradually we will increase the allocation and we will take it up to the 3% of the GDP. That is the promise. We don't know how long that promise will be translated into action. We only just believe what has been promised. But in the meanwhile, there is a lot of a lot of suffering, and we are already, as I was repeatedly telling, we are already stretched. To entire system is fully stretched.
Yeah, right.
Especially services like palliative and rehabilitative services are not at all on the radar, not at all in the gamut of things which are to be taken. It is more, the more focus is on mother and child, more focus is on communicable diseases and immunization, and palliative care and rehabilitation services doesn't come at all in the entire planning. It may be mentioned. It is only mentioned in our planning, but it is never get into, no resources are allocated. So at this particular juncture, our job is only we have to raise the resources. That's all. By philanthropy, by private participation, and by corporate participation, we have to raise the funds. That is the only option available to us. And as long as and we have to put the pressure. Luckily, the pandemic this year, that just year gone by, has brought that health onto the top of the agenda, top of the mind of the people. Everybody is looking at it because today everybody has seen ASHA and ANMs working for COVID and symptom tracking, and then also isolating them at home level. All that people are seeing, and they suddenly, especially in urban areas, from where these people have come, and the entire system depend on these people today. And a city like Bangalore, all the tertiary and secondary care institutions, which are spent billions of dollars of money is being spent on them, and all are shut during from month of March up to almost September 2020. They are all closed their services, and when there is a health emergency, public health emergency, they have no role to play. But all this neglected and resource poor institutions like primary health centers, they have become front and they have become warriors, and they could able to control this pandemic. So there is a thinking started in the system, at the planning level, at the commissioners level, at the politicians level, the thinking started. So that has to be translated into action. Let us hope we will get that uh, higher allocations and we will be able to achieve higher goals. But if we don't do it, if we don't increase it, and I can assure you, we are getting into more and more disasters. Because already we are, our health indicators are, some places we are poorer than sub-Saharan countries. And very shameful, very shameful health indicators that we have. Can you imagine? Almost 50% of our pregnant women are anemic, anemia. We are not able to give them good nutrition. It is shame on us. So we are getting into the more disasters if you don't increase the allocation. That's what I can tell you. And we have to, all of us, all the activists and all the professionals, and everybody have to put pressure on the system to increase the allocation. That is the only solution today. And the existing system is doing wonderfully well, but they are fully stretched. We have to augment and strengthen it.
Right. Thank you.
Thank you, Mr. Venkat. Dr. Juveria, you had a question?
Yeah, can I speak?
Yes,
Okay.
yes.
Yeah. So, sir, my question is, in a place, you have such a vast experience. I would like to benefit from it by asking you, what can we do? Like, I stay in Delhi, so what is happening here in Delhi? If you can give me an idea, and how I, as an individual, can help the advocacy with the community. Like, what is happening in south. You said that they are even the police is also helpful, and they are also a part of the palliative care in the society, as well as the public health is also involved. But here, what is the scenario here, sir? If you can tell me a bit about it, if I can understand what's happening.
If you are talking about as an individual, as a Dr. Juria want to do palliative care services, rehabilitative services, you have to be very specific what you want to do. In the sense, you have to, first of all, I was keep on telling you, we have to identify the geography. Let's say you can identify your ward or less than half of the ward, or whatever the possible for you as an individual, you can identify. You may identify some 20, 30, 50, 100 households. It's all depend on your capacity and your ability to do it. And you need to identify the people, those who require palliative care services and rehabilitative services. And then map it out. What are the needs? And then you as a nodal person and solicit or acquire or get the resources, because the resources are available. Resources are available scattered. So you as a motivated person, as a passionate person, your job is to pull all resources which are scattered into one place and deliver those into the needy place. That's how we should do it. But I'm telling you, I'm warning you, please don't do everything by yourself. That actually demotivate you, and also it will tire you out, and finally you will not do anything, and you will become more pessimistic, and you will become you will not be part of the system in the long run. So my with experience, what I'm saying is, as you are already motivated and want to do, your job is to gather all the resources together and deliver that and synthesize. Your job is to process all that and then deliver it to the needy people. And So then slowly build the institutions, and then that institution will be the supporting institution. That's how we should go about. And with my experience, I'll tell you, if you involve community, there will be never the shortage of money. I will tell you that. And we have started, Karnataka started with 5,000 rupees. And today our budget is around 40 crores per annum. And why I'm saying is, that if you are doing good work and if you are doing for the community selflessly, then you will never shortage of money. You will never shortage of resources. It will come from different sources. That is the only assurance you get it. How to do it? That all you have to figure it out based on the local condition. But only thing is, you have to, your job is to map out the resources, organize the resources, and deliver those resources in a form which will be helpful to the patient. That's how we should do it. I hope I could able to answer your question.
Yeah. Okay. Thank you, sir. Thank you.
Any more questions? Please unmute yourself.
Yes, ma'am. Can I speak?
Yes, Dr. Ajay, please.
Yes. Sir, in our Pallium India, we follow a systematic, sympathetic, empathetic, and careful function in Pallium India. That is the model. That is the Kerala model actually, and there is no constructions here. We follow even in COVID period. We with the other health beneficiaries, palliative system in palliative care, in COVID, palliative system. That is a very biased and very beautiful, very useful, not beautiful, very useful system to the society. And in the case of Paleo India volunteers, we are establishing social support, food support for patients, educational support for children, adding the local expertise, emotional support, basic nursing course, help and mobility. These are all the functions we are doing as the volunteers in Paleo India. That is the basic model, I think so. That's all. Thank you, sir.
Definitely, I agree on that. See, the Pallium India, what is doing is a pioneering work in the palliative care aspect in that particular sector. What Pallium India is actually developing different layers of models to support the community work. That is the pioneering work. It is definitely the model, and that's the reason I keep on telling that you follow the models, but based on your need at your conditions, because the entire model cannot be taken to different. Like for example, Arunachal Pradesh, conditions are different. Yeah, social conditions are different. So, but
In Toronto city, people always like this kind of palliative care. Even if the government system is also functioning there, but they all agree with this kind of system in Trivandrum city at least.
no, that's what I'm saying. It definitely is the best, and this is one of the best, and it is still evolving model. It is still need to be taken to the, we need to integrate into the health system. Today, that's what I'm telling you. It is not part of the health system. Today, palliative care is not in our top of our agenda. So, what you Pallium India is doing is excellent. There is no doubt about it.
Okay, sir. Thank you.
Thank you. Any more questions? We have time for 2 more questions. We have few people working in public health. We have Maibam, people from Manipur. We have Emmanuel from Mizoram. Any questions from anyone? All right. So I think we don't have any more questions. So I would personally like for you to recite one of the quotes that actually changed your life when you read it. So if Mr. Venkat, if you could talk about that quote yourself and tell us about that Swami Vivekananda's quote that actually made you change your life. So.
Oh yeah. So this is very my turning point. My life is basically I was very academically very sharp, and I was aiming for IAS, and was studying in a very top institution, and we were only used to discuss all the academic subjects, never on any of the non thing. One day I happened to go to an exhibition and pick up a book. That is Swami Vivekananda's book, and in that book, I read that book in that day, that night. And there are one or two. One is very, very striking that he said, I hold everyone as a traitor, having educated at the cost of the poor and pay least heed to them. So at the time I was studying, and I was all my life I didn't spend a single paisa for education. And I was thinking, oh, I was studying at the cost of the poor, and I never thought of them. And this man is calling me as a traitor. That was the time I thought I should do something. I had to work for the poor. That was one very, very striking. In fact, it was so striking. And in fact, I was to give up my studies and jumped into the social work. And then it took a very drastic turn towards social work, and then spirituality, where that was the one very important one. And the another thing which again Swami Vivekananda said the same thing is, he said, they alone live who live for others. The rest are more dead than alive. They alone live who live for others. The rest are more dead than alive. So this has again brought the importance of the purpose of life. Generally, what happens is we don't have that purpose of life. So he gave me that purpose of life. They alone live who live for others. The rest are more dead than alive. So these are the most important two, which is struck. Then over and above, there are so many what Swami Vivekananda. That's why inspired by Swami Vivekananda's teachings, and got into this social work, and then more into public health now.
Thank you, Mr. Venkat. So I'm going to ask the last time if any more questions are there. Or sir, would you like to talk about any memorable experience that you had in your line of work at Karuna Trust? Any story that you can share within like a few minutes? It would be great to hear your experience.
there are so many. In fact, during this COVID itself is so many moving experiences. Only thing is you have to pick it up now suddenly. So during this COVID, the lockdown, the entire town is locked down, and we Corona Trust is managing Bangalore City. We are managing 11 health centers. Out of 11, 2 are maternity homes, and then I can tell you 2 very moving experiences. One, and it was suddenly it stuck on us, and absolutely no precedents. And then the whole city is shut, and we are in the front line, and we don't have everybody, but the entire the manpower is at the front line. Not a single person took the leave. I'm talking about urban Bangalore. Not a single person, even though in spite of all the constraints, because ANMs, auxiliary ANMs, and especially ANMs, they're all come from the rural area to work in the urban area, and we have provided them, given them the accommodation, and then. And I was driving. I used to go to health centers to motivate our teams to go into the field and then identify the people, and the testing. We also put the testing in our health centers. Because the movement of vehicles also is a big thing. I was driving an ambulance so that nobody stops ambulance, and then. One of the big problems we used to face is food, and we had no time to go home or no time to get food from anywhere because the hotels are closed, and the neighboring people, they used to cook the food and they used to drop in our centers and give it to us. And the masks, one of the biggest problem in the very initial days was the masks and sanitizers. We don't know from where the masks used to come to us. People used to drop the masks in our office, and we used to get the parcels from different transport parcels. Some people used to parcel it to us, and it's very, how the community participation. If you are you are sincere and you are at the front line, how the people will respond. That was one experience which I have recent this thing. And another very moving experience is that one pregnant woman is in the labor. Almost, I think she's getting into labor and need to be admitted. And no, because she's from North Bangalore. We have our maternity home in the South Bangalore. And then all the maternity homes almost stopped functioning because of the COVID. And this lady went to six maternity homes, and all the places she was rejected because she didn't test it for COVID. And one of the other went there, they wanted a COVID test report. And so that they can take up the case. And then they came to, because they heard that Corona Trust Health Center, you can do the testing and we will give the report within 2 hours. Because those days, COVID testing was centralized and RT-PCR, and it used to take 3 days. So we tested the lady and she is negative, and immediately we have taken her to our maternity home and we conducted the delivery. And both baby and mother are healthy. That was the very, very striking point at that particular moment, because she was under duress, under tremendous stress after going to the 6 maternity homes and rejected all the places. And we were able to do it at very quickly without any problem, because we have everything. We have testing and we have a maternity home, and we could able to take care of the emergency obstetric care requirements also. So, and that was very fulfilling moment. So, in the process for last 32 years of my work, we keep getting this kind of inspiring moments that only will give you to sustain for next level. Because what happens is, when you are in the social work, when you are in the field, it's very difficult to sustain unless you internally sustain yourself. That's why there are different kinds of model. We say, let's say you get your energy from the main grid. It's like whenever the energy is cut, or you are powerless. If you are self-generating, like a generator, so your motivation and your all the energy should be self-generated. And this kind of incidences will help us to sustain for longer time. So that, because in the very gloomy picture, like what I explained to you, that we spend very low and our indicators are very poor, this is very, very gloomy picture. In this kind of a situation, that you have to be self-motivated, you have to be like a dynamo, where you need to generate your own energy. So these two incidents are moving experience in the recent past. Thank you.
Thank you, Mr. Venkat. Thank you for sharing those experiences. And I'm sure you've been working continuously for the last, it's almost going to be a year now, I think. So thank you so much for taking out time for us. We understand amidst your busy schedule, how difficult it would have been for you to even take out these 1.5 hours, but we really, really appreciate, and we're so grateful that you were able to join us today. Thank you so much for this lovely session. We had so much to learn, so many insights, so many experiences, and I wish we had more time to hear you out and hear more stories. But I'm sure there would be more coming up later in the coming months or years as well. Thank you so much, and our regards to the Corona Trust team for all the work that they do. And thank you, and to the audiences, thank you for being there today. The next session we have is on working with legislation, which is on next Saturday, which would be the NDPS story. We have a well-known lawyer called Tripti Tandon, who would be taking that session for us. So please do join us next Saturday. But thank you, Mr. Venkat. I hope you have a good weekend, a lovely weekend to the whole team here, and welcome to the Aarohan family. Thank you so much. Take care of yourselves.
Thank you. Thank you for having me. Thank you, Sriya. Thank you,
Thank you so